Welcome to Beyond Sound, the podcast for hearing implant professionals worldwide, produced by the Hearing Group, an international consortium of clinical and scientific centers of excellence dedicated to advancing hearing restoration. We are joined by Andrea Overton, adult audiology supervisor at the UNC School of Medicine, whose clinical and research expertise spans diagnostic audiology, cochlear implants, and auditory brainstem implants. Andrea will guide us through a crucial topic in modern implant audiology today: the Key Audiologic Considerations for Bilateral Cochlear Implantation, exploring practical, measured, and subjective advantages of bilateral implantation. She will touch upon the role of simultaneous versus sequential surgery and the many factors that shape patient outcomes, including binaural summation, head shadow effects, spatial release, and many, many more. Today's session will be moderated by Professor Javier Gavilán, the chairman of the Hearing Group, and contributing to the discussion are distinguished experts, Professor Hagr, Professor Brown, Professor Rajeswaran, Professor Hagen, and Professor Baumgartner, representing decades of surgical and audiological experience across leading implant centers. So now, get comfy and let's begin.
And we're back to North Carolina to meet you, Andrea Overton. She's an audiologist and adult audiology supervisor at the UNC School of Medicine. She provides expert care and services to patients seeking hearing solutions in the Chapel Hill area, and her special interests include diagnostic audiology, cochlear implants, and auditory brainstem implants. The Hearing Group, is delighted to have Andrea as one of our panelists today during the discussion and the presentation. She will deal with some audiological considerations of bilateral cochlear implants. Go ahead, Andrea.
Thank you so much for that introduction. So I thought it would be important to start with a discussion of the potential advantages with bilateral cochlear implantation as compared to bimodal stimulation, and thinking about how we talk about this with patients. So separating it into three different categories: the practical advantages, measured, and then subjective. I think from a practical standpoint, if we're implanting both ears, then we know that we're always implanting the better ear. That's no longer in question. And if we have both ears implanted, then there's never a time that if a patient were to have any kind of equipment malfunction, they're never off the air or without sound, which I think can be a real benefit to an individual. Additionally, I think having the potential for matching technologies, both externally and internally, can be a big advantage, and that's going to be more important for those who are having simultaneous implantation or have a shorter intersurgical interval. From a measured advantage standpoint, we can see an improvement in hearing and noise when sound sources are spatially separated, likely due to the cochlear implants being better at deciphering those intraoral level differences as compared to the timing differences. We can see a reduction in the head shadow effect, improved binaural summation or redundancy, improved squelch, and then, of course, sound localization. From a subjective standpoint, patients tend to report that it's more natural hearing. So as I mentioned before, feeling like it's kind of a surround sound hearing, and it's a little bit easier, less auditory fatigue, and more of an increased safety awareness. We also talk a little bit about whether it's simultaneous or sequential. So simultaneous indicating a single surgical procedure, sequential indicating two separate surgical procedures. We know that the complication rates are pretty similar across both. And so when we think about simultaneous, oftentimes that's not covered by all insurances. So we see that more often in our pediatric population than adults. And on that note, we've seen that infants who are 6 months and older have undergone simultaneous cochlear implantation, and that's really allowed for the development of the binaural auditory system for those folks. From a sequential standpoint, it does mean that there are two exposures to anesthesia, and that can often mean 2 times the surgical cost. From a hospital perspective, that likely means that there's going to be more profit with 2 surgeries versus 1. But I do think sequential allows for the asymmetric and progressive hearing loss population to receive cochlear implants as that other ear becomes a candidate. And this is really where the bulk of our adult population lies. I do think we need to consider the outcomes for folks who have a longer intersurgical interval. So by longer, I mean much greater than 10 years. For sequential bilateral implantation, we really approach the evaluation and talk to patients thinking about kind of a systematic approach of, is the patient making expected progress with their first side? If not, then we obviously need to address that first. We want to take a look at the status of the contralateral hearing ear. Is it a candidate on its own? Is the patient wearing a hearing aid, or have they ever worn a hearing aid on that ear? And how long has it been since their first device was placed? We also take a look at their bimodal benefit. So does the patient have any? In particular, looking at that in background noise. If they have no bimodal benefit that's tangible in the sound booth, or it's very minimal, that can be used as a really useful counseling tool. And then in 2019, Renee Gifford and Michael Dorman came out with a study that indicated that you could ask a patient whether or not they thought that they would benefit from a second cochlear implant. And that actually was a very highly sensitive measure for determining their outcomes in cochlear implant candidacy and their satisfaction with the device afterward. So that's something that we've incorporated into our practice. Insurance coverage is obviously important. It's not the fun part of the conversation, but unfortunately that can be the reason why someone may pursue or not pursue a cochlear implant. And then I think the coil site location shouldn't be overlooked. That's going to be especially important for folks who really like to use the off-the-ear processor like the Rondo 3, as the microphones are going to be located on that coil site. So having that symmetric is going to be important. From a post-implant consideration standpoint, I think of this in both bilateral mapping considerations as well as just general logistics. From a mapping point of view, loudness balancing is going to be important. So a patient may be comfortable in the unilateral condition, but with the summation of bilateral devices, balancing is definitely going to be needed. We try to match parameters where we can, so things like volume settings, processing strategy, stimulation rates, anything that we can match reasonably, we try to do so. Streaming is definitely easier when you have two matching cochlear implant technologies versus a cochlear implant and a hearing aid, because there can be so many variable platforms, manufacturers, et cetera, for hearing aid. Oral rehabilitation is a consideration. So what I might recommend could be different for simultaneous versus a sequential individual. And then from a remote control and app use, I know this sounds kind of silly, but if a patient is used to having their settings one way and each ear is slightly different, then the app itself will actually look a little bit off and become a little less useful to the patient. So having those kind of mirrored on both sides can be really important. And then from a logistics standpoint, I think it's really important that we determine the appointment length and the frequency. Oftentimes that's going to be determined by reimbursement. So for example, in the United States, Medicare does not pay any additional money for bilateral programming or additional time spent with the patient. So oftentimes there are clinics that will choose to see those patients on two completely separate days so that they are able to have adequate reimbursement for that. But that obviously brings on a whole host of other issues. I think we also have to consider, if we provide cochlear implants to all patients that could benefit, do we have the infrastructure, the staffing, the booth space, the availability to actually see all of these patients? And then of course, on that same note, do we even have the resources available? As alluded to before, there are a lot of countries that limit the number of cochlear implants per year, and a second side implant may be a lower priority than a first side implant. So it's important that we're good stewards of those resources. So I think in conclusion, in my opinion, there's no question that bilateral cochlear implantation can be incredibly beneficial to patients. I think we're in a really exciting time and uniquely positioned in this group to consider how we can make this feasible worldwide in a multitude of different practices. Thanks.
Well, thank you very much, Andrea. It was very interesting. So you bring up the issue of timing, and before entering into the discussion, let me give the word to Professor Baumgartner, who mentioned before that he wanted to say something. Baumi.
Thank you very much, Javi. Actually, it's my comment because of the bilateral benefit. What we observed, so we did the first bilateral adult implantation in 1996 and the first pediatric in 1997. And the leading benefit is depending actually on the age of life and the etiology of deafness. So the leading benefit for a newborn in bilateral hearing is to learn the bilateral hearing at all. And this is completely different from an adolescent with a progressive hearing loss, or an adult like us with sudden hearing loss, or an elderly person with a very prolonged over decades hearing loss. So all these candidates, depending on the etiology, have a different leading benefit of bilateral outcome. I think this is important at least to state, because it's also important for the different expectations of the bilateral candidates. And this also leads us to the fact that, of course, we need to implant single-sided deafness. We have extremely good experience. This I just want to say as a short statement. Thank you.
Okay, thank you very much. I like short statements and short answers so that we can have more discussion. I will bring you one more question from the chat, from the audience, saying, away from the financial issue, what if the patient refuses the second implant? Is bimodal fitting an alternative?
My answer is yes. I think ultimately we want there to be a treatment option on both ears that's appropriate. And if they can't or are not going to pursue a second cochlear implant, then I think a hearing aid is appropriate to put on the other ear.
Good. Rudolf, you want to ask something?
Yes, I missed the fitting. So in children, I think an argument for the bilateral simultaneous is the possibility to have a shorter fitting. And if we look for reasons to convince the insurance companies the ease of fitting, the shorter period of fitting should be one argument. What's your opinion on this? And my second question, you told us one presupposition is progress with the first side, but we have also cases when we fail with the first side, and what then to do? Doing the second side to try to get at least some hearing?
Okay, for the first question, Rahman, you're the god of the early fitting. What about fitting?
Well, I think we have long experience with the early fitting. So now almost all of our patients, they end up with the early fitting. If not the same day, they have it next day. Children and adult, bilateral or sequential. So in our experience, there is no really any explanation or any need to delay the fitting for the patients. And the other thing also, recently we have found that the earlier fitting actually give us better hearing preservation. And we think maybe the introducing the electricity early to the cochlea will minimize the trauma to the inner ear and actually give you less fibrosis and better outcome. And we published this one, and it seemed to be a promising future for our patient with the cochlear implant. And I don't think any need nowadays for any delay in fitting our patient because there is no really any evidence that the delay would be for any benefit of the patients. And I'm glad that we were able to convince Professor Hagen with this, and he accepted now. And actually, if we listen more and more to our patient, and we will find that the major concern for them is to wait for a month until they see the benefit of the surgery itself. So okay. I think that would be one of the best things we can do for cochlear implant patient.
Great. What was the second question, Rudolf?
The presupposition was that the patient has success with the first side. But what is with the patients who had low success with the first side? Maybe you hit the wrong ear. So is this an indication also to try the second side?
Andrea?
Yes, I think you have to consider each patient and their etiology. And there are some folks that will implant their poor hearing ear that we don't have high hopes for what that ear could potentially do, because that's the only thing that they're willing to do for their first side, with the understanding that I would have a different expectation for outcomes on the second side. So I think it has to do a lot more with the counseling, and it's not a reason not to pursue a second side, but I think you have to take it case by case and have counseling that's appropriate for each of those individuals.
Ranjit, you agree? You're muted. Right. Ranjit, you're muted.
I agree with her. I completely agree with her. You need to go case by case, and there's no reason why you should not implant the second side if the expectations are very realistic.
One of the things we do in our center is to do bilateral simultaneous. So basically, adult and children, if they do bilateral, you don't know which one would be the best. But in reality, if they become together, definitely they will be better than one alone.
Good. And one of my doubts is concerning timing. Which is the maximum time you can leave between the first and the second? Both in children and in adults. Andrea.
So I think for optimal performance, I think like 7 to 10 years is an ideal amount of time. That's not to say that I wouldn't implant a second side that was 20, 30, 40 years later.
You will not do it. You will not prevent doing it after 20, 30 years.
If that ear had some type of amplification on the other ear, and the patient has a realistic expectation of what's their goal with this. Is this so that they have some sound awareness on the other side? That's very different than if they're expecting it to be, the same exact sound quality and speech perception. So I think it depends on the patient, and it depends on what their ultimate goals are.
You agree, Ranjit?
Two important points in this.
Yeah.
The first one is the reason for the second device, even after 20, 30 years. We need to understand from them why they want to get the second implant done, why they want the second ear to be implanted. And if the reason is reasonably enough to achieve, and then we can go ahead. If not, I think we should give them, not discourage them, but just tell them what the facts are, And from our experience, I agree with that 10 years is the optimal time. And we have a couple of patients who we implanted 12 and 14 years. They were non-users of the second device now. So we strictly recommend less than 10 years, not more than that, unless otherwise the patient insists and if the expectations are realistic.
But if it's more than 10 years, because Andrea mentioned that she will not stop doing that if it's more than 20, 30 years, she said, will you do it also?
Okay. Yes, we would do it. That's what, 2 reasons. One, we need to understand why they want the second side implanted even after 20, 30 years, one. And the thing is, that if the reason for them for going for the second device is reasonable enough to achieve, if that target is reasonable enough to achieve, then fine. Otherwise, we give them realistic expectations. And it's absolutely the choice of the patient to decide. And just because they cannot achieve good speech in noise, like, how you do it in simultaneous, doesn't mean that we should prevent them from using the other ear.
Good. Okay, go ahead, Andrea.
I was just going to give a patient example. I had a patient who was implanted as a little baby, was 20 years old, has one ear implanted, and then had their own child like 25 years later, and wanted to get the second side because they felt like they were having a hard time localizing or even having awareness on the other side, and were worried about crossing the parking lot with a child. So they didn't have the expectation they would have a whole lot of speech understanding, but for them, that was a huge part of their quality of life. So I think in the right circumstance, it's reasonable.
Thank you for joining us for this episode of Beyond Sound, brought to you by the Hearing Group. We hope today's discussion on the audiologic considerations for bilateral cochlear implantation offered valuable clinical insights and enriched your expertise. If you'd like to explore more brilliant resources by Hearing, visit boost.hearing.com. Our educational platform featuring masterclasses, surgical symposia, and expert-led courses designed to support continuous learning across the entire field of hearing restoration. What might also spark your interest is the fact that many courses available on the Hearing Boost are internationally accredited. Before we say our goodbye today, make sure to subscribe to Beyond Sound on Spotify or YouTube so you never miss upcoming episodes with global leaders in implant science. To stay connected with the hearing experts, follow us on LinkedIn, Instagram, YouTube, and Facebook at Hearing Group. Thank you for listening. Until next time, this is Beyond Sound.